In this video, we will cover conduction abnormalities. Heart conduction system sends the signal to start a heartbeat. It also sends signals that tell different parts of our heart to relax and contract. This process of contracting and relaxing controls blood flow through our heart and to the rest of our body. Normally, electrical signals control every heart muscle contraction and travel from the atria or the upper chamber of the heart to the ventricles or the lower chambers. Even changes to impulse that last only a fraction of a second can cause heart block. Sometimes heart block makes it difficult for the heart to pump blood properly through the circulatory system. So the muscles and organs, including the brain, do not get enough oxygen to function properly. A partial heart block happens when there is a delay of the electrical impulses or they move slower than usual. A complete heart block is when the electrical signals stop completely. The heart rate can drop to about 40 times per minute or slower. Heart block can cause lightheadedness, fainting, and palpitations. Depending on the severity of the heart block, it can be a dangerous, life-threatening emergency. When assessing the rhythm strip, the underlying rhythm is first identified, for example, sinus rhythm, sinus arrhythmia. Then the PR interval is assessed for the possibility of an AV block. AV blocks occur when the conduction of the impulse through the AV nodal or bundle of His area is decreased or stopped. Causes of heart block are impaired tissue at the level of the AV node prevents the timely passage of the wave of impulse through the conduction system. These blocks can be caused by medications such as digitalis, toxicity, beta blockers, calcium channel blockers, etc. It can be caused by ischemia or inferior wall myocardial ischemia and infarction, hypothyroidism or Stokes-Adam syndrome, Lyme disease, valvular disorders, cardiomyopathy, endocarditis or myocarditis. If the AV block is caused by increased vagal tone, it is commonly accompanied by sinus bradycardia. Example of increased vagal tones are long-term athletic training, sleep, coughing, suctioning, pressure above the eyes or on large vessels, anal stimulation. Signs and symptoms of heart block. The clinical signs and symptoms of a heart block vary with the resulting ventricular rate and the severity of any underlying disease process. Whereas first-degree AV block rarely causes any hemodynamic effect, the other blocks may result in decreased heart rate, causing a decrease in perfusion to vital organs such as brain, heart, kidneys, lungs, and skin. A patient with a third-degree heart block caused by digitalis toxicity may be stable. Another patient with the same rhythm caused by acute MI may be unstable. Healthcare providers must always keep in mind the need to treat the patient, not the rhythm. The treatment is based on the hemodynamic effect of the rhythm. Heart block can cause lightheadedness, fainting, and palpitations. Depending on the severity of the heart block, it can be dangerous, life-threatening emergency. There are 3 types of heart block. These types range from mild to severe. First-degree heart block, second-degree heart block, third-degree heart block. There are 2 types of second-degree heart block, Mobitz type 1, Mobitz type 2. Now, we will cover each type in detail. Now, let us see first-degree AV block or heart block. In first-degree heart block, every impulse is conducted to the ventricles, but the time of AV conduction is prolonged. After the impulse moves through the AV node, the ventricles usually respond normally. First-degree AV block is really a conduction delay rather than a block. Every impulse is conducted to the ventricles but in a delayed manner. First-degree AV block occurs when all the atrial impulses are conducted through the AV node into the ventricles at a rate slower than normal. The rate is usually within normal limits but depends on the underlying rhythm. For example, the underlying rhythm may be sinus bradycardia with first-degree AV block. The rhythm is regular. The P waves are normal configuration with one P wave preceding each QRS complexes, and the QRS duration is usually narrow. The distinguishing feature of a first-degree AV block is that the PR interval is greater than 0.20 seconds due to the conduction delay. all PR intervals are consistent in that they all measure roughly the same length. Causes of first-degree AV block. It may be a normal finding for some individuals, or it may be due to a disease condition. First-degree AV block is associated with increasing age. Some causes of first-degree block include AV nodal ischemia, which may occur from an inferior MI. Digitalis toxicity or toxicity to other medications such as beta blockers, calcium channel blockers, frecanide, and narcotics. Excessive vagal stimulation. Post-cardiac surgery due to edema in the AV junction or calcification of the AV node. First-degree AV block is associated with coronary artery disease, rheumatic fever, hypothyroidism, electrolyte imbalances, for example, hypokalemia. First-degree block is not serious. Patients are asymptomatic. Generally, first-degree atrioventricular block does not cause hemodynamic compromise, so the patient remains without symptoms. If the dysarrhythmia is due to a medication, the drug should be stopped or the dosage decreased. If the dysarrhythmia is due to an acute MI, the patient should be monitored closely for progression to a more severe AV block. There is no treatment for first-degree AV block. Treatment of associated conditions may be considered. Monitor patients for changes in heart rhythm. For example, we have to monitor the patient whether the patient is going to have a more serious AV block. Next is second-degree AV block. In second-degree block, not all of the impulses from the atria are conducted to the ventricles. The SI node is firing at regular intervals, but some of the impulses are blocked at the AV junction. There are two types of second-degree AV blocks. Mobitz type 1, also called Wenger-Beck. Mobitz type 2, which is more serious than type 1. Just as the PR interval was a distinguishing factor in first-degree block, the PR interval is a distinguishing factor differentiating type 1 from type 2 second-degree block. Now we will see second-degree AV block type 1. Second-degree AV block type 1 occurs when there is a repeating pattern in which all but one of a series of atrial impulses are conducted through the AV node into the ventricles. Each atrial impulse takes a longer time for conduction than the one before, until one impulse is fully blocked, because the AV node is not depolarized by the blocked atrial impulse. The AV node has time to fully repolarize so that the next atrial impulse can be conducted within the shortest amount of time. Type 1 second-degree AV block includes a gradual lengthening of the PR interval. AV conduction time is increasingly prolonged until an atrial impulse is not conducted and a QRS complex is blocked or missing. Type 1 AV block most often occurs in the AV node, but it can occur in the His-Purkinje system. Characteristics of a second-degree AV block type 1. Ventricular and atrial rate. Atrial rate is regular, but ventricular rate may be slower because of non-conducted or blocked QRS complexes resulting in bradycardia. The rhythm appears irregular due to the non-conducted P waves or P waves that are not followed by a QRS complex. The PP interval is regular if the patient has an underlying normal sinus rhythm. The RR interval reflects a pattern of change. Starting from the RR that is the longest, the RR interval gradually shortens until there is another long RR interval. The P waves are normal, but some P waves are not followed by a QRS complex. Shape depends on underlying rhythm. QRS shape and duration is usually normal but may be abnormal. Duration may be narrow. Sometimes we may see missing QRS complex. Once a ventricular beat is blocked, the cycle repeats itself with progressive lengthening of the PR intervals until another QRS complex is blocked. The PR interval lengthens with each consecutive cardiac cycle until the P wave is not followed by a QRS complex. The pattern of progressively longer PR intervals and dropped QRS repeats itself. The PR intervals becomes longer with each succeeding. The impulse from a SN node take an increasingly longer time to conduct through the AV node until one is unable to conduct to the ventricles. The conduction pause then allows the AV node time to recover so that the next impulse starts the cycle over again with an initial shorter conduction time. After the first QRS in the strip, there is a P wave that is not conducted into the ventricles and therefore is not followed by a QRS. The PR interval of the second cardiac cycle is 0.24 second. The PR interval of the third cardiac cycle is 0.28 second. The PR interval of the fourth cardiac cycle is 0.36 second, and then a non-conducted P wave is seen again. This rhythm is cyclic and will always present with progressively lengthened PR intervals until a QRS complex disappear, and then it will repeat itself. P is to QRS ratio will be 3:2, 4:3, 5:4, and so forth. Etiology of type 1 AV block. Type 1 AV block may result from drugs such as digoxin or beta blockers. It may be associated with coronary artery disease and other diseases that can slow AV conduction. The conduction delay through the AV node is thought to be caused by AV nodal ischemia from occlusion to the right coronary artery from acute inferior wall MI or from increased parasympathetic stimulation. It is usually transient and rarely progresses to a second-degree AV block type 2 or third-degree AV block. Clinical significance. Type 1 AV block is usually a result of myocardial ischemia or inferior myocardial ischemia. It is generally transient and well tolerated. However, in some patients, for example acute MI, it may be a warning sign of a more serious AV conduction problem, that is complete heart block. A symptomatic patient may need atropine or a temporary pacemaker to increase heart rate, especially if the patient has had an MI. If the patient is asymptomatic, observe the rhythm closely. Have a transcutaneous pacemaker on standby. Bradycardia is more likely to become symptomatic when hypotension, heart failure, or shock is already present. This dysarrhythmia is usually asymptomatic as the cardiac output is not significantly affected. If the patient does become symptomatic and the rhythm is low, treatment will follow that for sinus bradycardia using atropine as the first-line drug of choice. Temporary pacing should be considered depending on the patient's symptoms. Now we will see second-degree AV block type 2. Second-degree AV block type 2 is less common than type 1. It is more serious than type 1 because it may suddenly progress to a third-degree AV block and because it is usually bradycardic in nature. The block occurs below the bundle of His in the bundle branches of the conduction system. Second-degree AV block type 2 occurs when only some of the atrial impulses are conducted through the AV node into the ventricles. In type 2 second-degree AV block, a certain number of impulses from the SN node are not conducted to the ventricles. This occurs in ratio of 2:1, 3:1, and so on. That is, 2 P waves to 1 QRS complexes, 3 P waves to 1 QRS complexes. It may occur with varying ratios. Characteristics of second-degree AV block type 2. Atrial rate is usually normal. Ventricular rate depends on the degree of AV block, but the ventricular rate is lower than the atrial rate. The atrial rate is greater than the ventricular rate because of the non-conductive P wave. The ventricular rate is often very slow. When the P wave are blocked at regular intervals, such as 2 P waves for every 1 QRS, the ventricular rate will be regular. If the non-conductive P waves are blocked in a random pattern, the ventricular rate will be irregular. Atrial rhythm is regular, but ventricular rhythm may be irregular. The PP interval is regular if the patient has an underlying normal sinus rhythm. The RR interval is usually regular, but may be irregular depending on the P is to QRS ratio. P wave is usually in front of the QRS complex. The P waves are normally in size and shape depends on underlying rhythm. In type 2 second-degree AV block, a P wave is non-conducted without progressive PR lengthening. This usually occurs when a block in one of the bundle branches is present. R wave will be irregular. Unlike type 1 block, the PR interval is constant for the conducted beats. The PR interval may be normal or prolonged in duration and remains constant on conducted beats. The PR interval is constant for those P waves just before QRS complexes. The QRS duration may be normal or it may be wider than normal, more than 1-2 seconds, because of a delay or blockage in the conduction below the bundle of His, that is bundle branch block. P is to QRS ratio will be 2:1, 3:1, 4:1, 5:1, and so forth. Next is etiology. Type 2 AV block is associated with rheumatic heart disease and drug toxicity. It may occur in patients with left coronary artery disease, such as an anterior wall MI, because the bundle branch receives their blood supply from the left coronary artery. Type 2 block may also result from other forms of heart disease. The patient may experience hemodynamic compromise if there are frequently dropped P waves, resulting in a slow ventricular rate and inadequate cardiac output. Clinical significances. Second-degree heart block might cause dizziness, fainting, the feeling that your heart skips beats, chest pain. The patient may have trouble breathing or shortness of breath. Patient may have nausea, fatigue. The reduced heart rate often results in decreased cardiac output with subsequent hypotension and myocardial ischemia. This may be serious in some cases. Type 2 AV block often progresses to third-degree AV block. It is associated with a poor prognosis. Type 2 AV block is an indication for a permanent pacemaker. The treatment for unstable patients with second-degree AV block type 2 is immediate temporary pacing, transcutaneous pacing, or the insertion of a temporary pacemaker may be needed before inserting a permanent pacemaker if the patient is symptomatic. For example, if the patient is having hypotension or angina. Atropine 0.5 mg IV may be considered while waiting for the pacemaker, but its administration should not delay temporary pacing. If temporary pacing is ineffective, preparations should be made for a permanent pacemaker and expert consultation should be obtained. Next is third-degree AV block. Third-degree AV block or complete heart block. Third-degree AV block is a medical condition in which the electrical impulses generated in the SA node in the atrium of the heart cannot propagate to the ventricle. In complete heart block, there is complete absence of AV conduction, with none of the supraventricular impulses conducted to the ventricles. The perfusing rhythm is maintained by junctional or ventricular escape rhythm. Alternatively, the patient may suffer ventricular standstill leading to syncope if it is self-terminating, or sudden cardiac death if it is prolonged. Third-degree AV block occurs when no atrial impulse is conducted through the AV node into the ventricles. Because the impulse is blocked, an accessory pacemaker in the lower chamber will typically activate the ventricles. This is known as the escape rhythm. Since the accessory pacemaker also activates independently of the impulse generated at the SA node, two independent rhythms can be noted on the electrocardiogram. In third-degree AV block, two impulses stimulate the heart. One stimulates the ventricles, represented by the QRS complex, and one stimulates the atria, represented by the P wave. P waves may be seen, but the atrial electrical activity is not conducted down into the ventricle to cause the QRS complexes, the ventricular electrical activity. The atria and ventricles beat independently of each other. Having two impulses stimulate the heart results in a condition referred to as AV dissociation, which may also occur during ventricular tachycardia. The P waves with a regular PP interval, in other words, a sinus rhythm, represent the first rhythm. The QRS complexes with a regular RR interval represent the second rhythm. The PR interval will be variable, as the hallmark of complete heart block is the lack of any apparent relationship between P waves and QRS complexes. Second-degree AV blocks are incomplete blocks because some of the impulses are conducted through the AV junction to the ventricles and some of the impulses are blocked. Third-degree AV block is referred to as complete heart block because none of the impulses from the atria are conducted through the AV junction to the ventricles. Characteristics of complete heart block. The atrial rate is greater than the ventricular rate. The ventricular rate is determined by the site of the ventricular pacemaker. The atria may be paced by the SA node or by an ectopic focus in the atria. The ventricles may be paced by the AV node, the bundle of His, or the Purkinje fibers. Depends on the escape rhythm. It can be idionodal or idioventricular and underlying atrial rhythm. The ventricular rate is lower than the atrial rate. Both the atrial and ventricular rhythms are usually regular, but they have no relationship to each other. The PP interval is regular and the RR interval is regular, but the PP interval is not equal to the RR interval. QRS shape and duration depends on the escape rhythm. With the junctional rhythm, QRS shape and duration are usually normal. With idioventricular rhythm, QRS shape and duration are usually abnormal. The QRS complexes may be narrow or wide depending on the location of the escape pacemaker. Narrow QRS complexes are indicative of an escape pacemaker at the AV junction and will usually have a rate of 40 to 60 beats per minute as in the junctional escape rhythm. Wide QRS complexes are indicative of an escape pacemaker in the ventricles and will usually have a rate of less than 40 beats per minute. The QRS complexes are equal distance apart, but there is no relationship between the P waves and the QRS complexes. The P waves are normal in shape and size and are equal distances from each other and depends on underlying rhythm. There is no consistent PR interval because the atria and ventricles are beating independently of each other. Thus, all the PR intervals are different. Complete heart block may deteriorate into a fatal dysarrhythmia such as ventricular asystole, ventricular tachycardia, or ventricular fibrillation. More P waves than QRS complexes are seen. Pathophysiology of complete heart block. Complete heart block is essentially the end point of either Mobitz 1 or Mobitz 2 AV block. It may be due to progressive fatigue of AV nodal cells as per Mobitz 1. For example, secondary to increased vagal tone in the acute phase of an inferior MI. Alternatively, it may be due to a sudden onset of complete conduction failure throughout the His-Purkinje system as per Mobitz 2. This can be secondary to septal infarction in acute anterior MI or as a result of progression of conducting system disease causing true trifascicular block. The former is more likely to respond to atropine and has a better overall prognosis. Complete heart block may be caused by medications such as digitalis toxicity and by degenerative heart disease. It may also be caused by an acute MI and myocarditis. Factors may increase the person's risk of developing heart block such as a heart attack that results in damage to the heart's electrical system. Another heart condition such as coronary artery disease, cardiomyopathy or heart failure. Other health conditions such as diabetes, high BP or Lyme disease. Medications that slow the heart's electrical impulses such as beta blockers or calcium channel blockers. Heart surgery that leaves scar tissue in the heart. Electrolyte abnormalities that can cause a temporary disruption to the heart's electrical system. Degeneration or aging of the heart's electrical system. Third-degree heart block is the most severe form of heart block. The electrical signal does not move to the lower chambers of the heart. In this case, the lower chambers beat at a much slower rate, and the upper and lower chambers do not beat subsequently, one after the other as they do normally. The heart fails to pump enough blood to the body. This leads to a slower, more irregular heart rate, which can lead to symptoms such as shortness of breath, dizziness, feeling tired or fainting, chest pain. Third-degree heart block is more common in people with heart disease. It can also worsen pre-existing conditions such as heart failure. It can cause a loss of consciousness and even sudden cardiac death. Some people are born with heart block. It can happen as a result of a heart defect or a condition the baby's mother had during pregnancy known as congenital heart block. People with third-degree heart block typically experience severe bradycardia, hypotension, and at times hemodynamic instability. Third-degree heart block requires prompt treatment. Without a pacemaker, there is a serious risk of a heart attack. However, it is more common for heart block to develop over time. As a person ages, the nerve that connects the top and the bottom of the heart may start to fade. Some people with a milder form of heart block may not experience any symptoms. Others may experience intense tiredness, a slow or irregular heartbeat or palpitation, shortness of breath, lightheadedness, dizziness or fainting, chest pain or discomfort. People may experience difficulty with exercise or exertion due to the heart having trouble pumping blood around the body. People with heart block may appear healthy, but they may have an underlying heart problem. This is an emergency that needs medical help right away. Third-degree heart block, which can be fatal anytime. In the absence of symptoms, a cardiologist typically diagnoses heart block during routine testing for other heart issues. A diagnosis involves a detailed medical history, physical exam, and certain diagnostic tests. An electrocardiogram records heart activity and is the most common test doctors use to diagnose heart block. Holter monitor is used to help diagnose heart block. This uses a portable device that a person wears under their clothing that records all of their heartbeats. The Holter monitor records information about the heart's electrical activity while the person goes about their normal activities for 1 to 2 days. A cardiac event monitor is another type of device that records the heart's electrical activity. A doctor may use it to diagnose heart block when a person's symptoms are less frequent. A person wears the monitor and activates the device when they feel symptoms. A person can use a cardiac event monitor for up to 30 days at a time to monitor their symptoms. Implantable loop recorder is a small heart recorder that is placed underneath the skin overlying the heart. It may be used to diagnose heart block when a person's symptoms are less frequent. This device continuously monitors a person's heart rate and rhythm, and it can record activity for up to 3 years. Next is treatment. Treatment for heart block depends on the type a person has and what is causing it. For first-degree heart block, treatment for a person may be as simple as self-monitoring their pulse, attending regular checkups, and knowing when to seek help for more problematic symptoms. People with second or third-degree heart block may need a pacemaker. The nurse should prepare for emergency temporary pacing in patients with symptomatic third-degree AV block. Atropine 0.5 mg IV may be given while waiting for pacemaker to a total of 3 mg. Epinephrine or dopamine infusion may also be considered while waiting for the pacemaker or if the pacemaker is ineffective. If temporary pacing is ineffective, the nurse should prepare for permanent pacemaker insertion. If a person have electrolyte abnormalities, it should be corrected. A pacemaker is a small battery-operated device that sends electrical impulses that help keep the heart beating at a regular rate and rhythm. A person can use it temporarily outside of their body or implanted in their chest or abdomen for more permanent use. A doctor can set many pacemakers to produce an electrical impulses only when needed. Some can sense if the heart stops beating and produces an electrical impulses to restart it. The battery can last many years. Cell phones, personal stereos, or household appliances do not affect pacemakers, but a person with one should avoid magnetic fields such as from a magnetic resonance imaging scan. People who have pacemaker also need to avoid strong magnetic fields. They should not undergo an MRI scan. They also need to seek alternative security screenings in places such as airport. People with heart block may have an increased risk of other types of arrhythmia such as atrial fibrillation. They may also have a high risk of heart attack. Heart block is not always avoidable, but a person can reduce the risk of heart disease by consuming a healthy diet, exercise regularly, minimize alcohol consumption, and avoiding tobacco. Most people with heart block can lead normal lives. If a doctor diagnoses a person with heart block, they should work with a cardiologist to develop the right treatment and management plan to stay on top of their heart health. A person who has heart blocks should speak with the doctor if they experience chest pain, dizziness, faintness, weakness, racing or skipped heartbeats, shortness of breath, swelling in their legs, ankles, or feet. with heart block. Complications may include fainting with injury, low blood pressure, and damage to other internal organs, and cardiac arrest. Prevention of heart blocks focuses mainly on managing the risk factors. A healthy lifestyle contributes to overall good health, including heart health. Exercise, eat a well balanced diet, and do not smoke.